So yes, I was given the task, which I always think is interesting, of how to prioritise hepatitis C treatment from the perspective of the medical community. I wondered what that was, but never mind. I have declarations. In particular, I need to highlight that I have Gilead Science and AbbVie provide funding for independent investigator-initiated research grants to my work. So, but the question really I said is why should I be prioritising hepatitis C treatment? And from a slightly confused medical person's perspective, because I actually just wondered about the question even. So, a medical perspective means that I am putting on my clinical doctor infectious diseases specialist hat, not my public health or research hat or whatever other hat I might care to wear. So I was thinking I'm being a doctor today. So, direct-acting antiviral treatment, over 90% cure, minimal side effects, 8 to 12 weeks duration, what's not to like? And which one of my patients doesn't want them? My simple thoughts was none so far. Nobody's actually said, no, I don't want it. No, go away, see you later. None. So, from a medical perspective, my priority is to treat the patient in front of me, whoever they are and whatever their circumstances. If they're sitting to my side rather than across the desk, because people in our clinic sit to the side with us so we can chat. So if a patient in front of me wants treatment, then that is who I prioritise. Done. So I think I've finished my talk. I'd like to acknowledge me. Because I actually think it's that simple. I truly do. I think it's that simple from a medical perspective. Somebody walks in and says, I would like treatment. I say, sounds fair enough to me. Let's check you've got hepatitis C. Let's check you've still got the virus in the blood. Yep. They have to go away because I don't have point-of-care tests. Come back. What do you reckon? You're hepatitis C positive, this is genotype. Oh, I'd still like treatment. Rightio, let's get going then. It's real tough. I have a very difficult job. So, but I suspect that is not the question I was being really asked to address, and I thought I'd better sound scientific-y and all that kind of stuff, otherwise I can't have all that crap written about me in the book. So, in a setting where there is limited access to care and treatment, who should be prioritised? And the issue with this question is primarily predicated on that treatment is expensive, and that it's not necessarily the situation everywhere in the world. It's unlikely to stay that way. And I've actually, from the very beginning, refused, and I still refuse to accept the premise of the argument about cost. It was just the beginning of a conversation. Now, in my point of view, the fact that the conversation started in a ridiculous place of supposedly $1,000 a pill has been an enormous waste of energy. An enormous waste of energy by a number of people in this room having to have discussions about a cost up there. We all knew it was going to come down to here. And it's going to get smaller and smaller. Everybody knew that. Anybody that worked in the HIV field knew that. But we're being asked to start a conversation. In my view, what's happened over the last 2 years is they've just asked us to waste a large amount of time. And I suspect if people had their time again, they might have rethought that particular question. Because as Tracy put into details, and so I won't spend time on this, is that the cost is getting cheaper. We know it's going to get cheaper, and it already is. And so Manal highlighted and others have already highlighted. So, it's also predicated on the idea that a growing burden of disease in F3 and 4, and this must be treated first, because all of these people are going to get sick, and people are dying globally of their hepatitis C, and that this group who's getting sick is this F3, F4 area, and we've got to be worrying about it. And so I'm just showing this is worldwide. And also, in terms of guidelines being written about who's the highest priority, who's the second highest priority, and I'd like to acknowledge Natasha Martin, who gave me these slides, for both in the US and at EASL. You know, this is being sort of accepted as a reasonable way forward. But what makes something a medical priority? And so I began to think about it. Decompensated liver disease. Is that a medical priority? Like, because the person's really sick and they need a transplant? Quite possibly. Compensated liver disease. Well, how long will it be before that person actually decompensates to need the liver transplant? F3, stop progression. There's no need for ongoing follow-up post-treatment. So the reason why we're actually prioritising F3 is because that person might progress to F4, and we don't want to be doing a FibroScan and an ultrasound every year afterwards and all of these things. That's when they become at risk of hepatocellular carcinoma. So we're making a decision of F3 about something that might happen in 3 or 4 years' time. Should we prioritise a young female who wants treatment prior to getting pregnant because she's got a 6% probability of passing it on to mother to child? So whenever my colleagues, when I have this discussion, I've had it often with them, are saying it has to be F3, F4, and I say, why? And they say, oh, because of this cancer business. So we're prioritising cancer, but it might take you a while to go on to get cancer, and not everybody does. Will you treat the young female with the 6% probability? They always go, oh yes, I would treat that person. So the young male who wants to be a boxer, or wants to join the Defence Force, but needs his hepatitis C treated beforehand, will we prioritise that person? Will we prioritise the 62-year-old grandmother who wants help to look after the grandchildren whilst her children are at work so they can live in a better area while the school's in, but she's too exhausted? How about the 43-year-old who injected occasionally but now spends a whole lot of time worrying because I have something in me where I'm told I might go on to get liver cancer or my liver might fail and you won't treat me and I've got to worry about that for how long? You want me to worry for 5 years, 10 years, 20 years? What's a reasonable length of time for me to worry when I know you've got a drug for me that could cure me? Or a person who injects drugs but just wants to get rid of the virus and promises I'll never, ever, ever share again. So they're being good. But how about the person who injects drugs, who's actually going through a pretty hectic phase, but just wants treatment, doc? Because I just do. Because why can't I? Because they've heard there's a cure. And so to me, when somebody sits in front of me with all of these things, because I've seen all of those people, when I put on my medical hat, I prioritise all of them, whoever sits in front of me, in my view. So I shall now remove my medical hat, though, and look at it, because that's really what this is. And I think the doctors in the audience have to recognise that. The clinicians amongst us have to recognise that when we subscribe to the theory of prioritisation, we're actually not putting on our medical hats. We're accepting stuff being told to us by others around money. Okay? It's not our medical hat we're putting on when we agree with guidelines that prioritise people with severe liver disease. There's a difference with queuing and stuff, and if the other speakers have had, but I think it's really important for the clinicians to understand this. What they're talking about when we begin to say who gets prioritised is public health hats, it's economic hats, it's many other hats, but it's certainly not a medical hat. So, this was touched on yesterday by Jordan about the Sustainable Development Goals, and I think this is really, really important, that we basically have had hepatitis named, and it would have been nice for it to have been basically to end the epidemic, but to combat, at least it's in there. And the other important thing about these Sustainable Development Goals is the concept of universal health coverage. It's a key Sustainable Development Goal that needs to be thought about and that we need to be part of pushing this. So if we as clinicians want to be putting on non-medical hats, put on that non-medical hat as opposed to the restriction. And we should have a vision of where viral hepatitis, this is WHO's vision at the moment, of where world where viral hepatitis transmission is stopped and everyone living with hepatitis has access to safe, affordable and effective care and treatment and elimination. And the elimination targets seem heroic, but then I've just come from Georgia where they're planning to eliminate by 2020. Now, if Georgia can eliminate by 2020, or at least feel like they can give it a whirl, and if Egypt can be doing the type of stuff they're doing, then I've decided we've all got to lift our eyes up a bit and be deciding to be a little bit more heroic than what we currently are. So, we need new cases of chronic hepatitis C to decline by 80%, and to reduce hepatitis C deaths by 65%. And I've decided I no longer am going to think of these as being heroic, but actually just let's get on and get going at it. So, achieving these targets, there's sort of ways to do it, but one of the key things is diagnosis. Our speakers previously have indicated you can't go in for treatment if you don't know you've got it, so we've got to work out how to fix this up and get more people diagnosed. Treatment, we've got good drugs. I totally agree with the concept, the shorter the better, and we need continual work on that because it is an issue for people in terms of having to go back to see doctors. We should not be making assumptions about people's lives. And harm reduction, it is vitally important that we do not forget the things that don't cost much, that are simple, and that there's clear evidence that they're effective. And we have to keep on asking our politicians and everybody, why are these not available to everywhere in the world? And what has the war on drugs done that it's made that we don't take an evidence-based approach to things that are really, really simple? Natasha Martin and Peter Vickerman did some models back in sort of the early 2010s and the last few years, which basically showed that in terms of treating people who inject drugs, elimination models, but there's other models as well, that we can actually eliminate hepatitis C if we just maintain a constant level of the number of people being treated. The number of people you needed to treat per people who injected drugs was relatively very low, and really one of the major kind of things that impacted on it was the background prevalence of disease in those populations, and it applies to the models in terms of elimination more generally as to how hard you have to work. Now, my group has just finished doing some work on really basically asking the question for in Australia whether or not what is required to meet the WHO elimination targets. And in essence, let me just check that I'm going to get this right. In essence, if you don't treat anybody, so this is to hit the targets to do with, to reach the incidence targets of the number of new cases. If you treat people with significant disease, or if you treat people who inject drugs. And in essence, we only need to be treating about 58 per 1,000 people who injected drugs to reach that elimination target of transmission. In the second panel, we basically looked at the annual liver disease and what would be the impact of treating people in terms of that. And importantly, it goes up. But what we found is if you treated people with significant disease, you reduce the deaths. But just as importantly, if you treated that same number of people who injected drugs, about 58 per 1,000, you actually stopped the deaths as well at about the same time. The key here is the curve looked like this, but you actually managed to get to both elimination targets by focusing on people who injected drugs, current injectors. And what you ended up with a prevalence of 6% here, as opposed to if just treating advanced liver disease of 34 to get the same target. So something to think about in terms of what we're trying to achieve and who we should be prioritising. That's why, to me, as a clinician, I prioritise the person in front of me. Because the thing that you need to note, because I'm not saying you should only treat current injecting drug users, because your cumulative deaths was much less if you treated people with advanced liver disease. So you don't not treat, because it would be ridiculous, the person sitting in front of you with F3, F4, because you have cumulative deaths. But in fact, if we're being sensible about it, in terms of just saving community money, hitting both elimination targets, in the long run turning off the tap of infection, one could argue just treat people who injected drugs. So I said this will not be acceptable to many of my colleagues, that I would allow that number of accumulative deaths. So I said, can we have a go at also adding in for the first 5 years, which when you think about your clinics, the hepatologists, the infectious diseases specialists here, you've already got people sitting at your clinics. I said they're already going to be there. They're just going to treat them anyway. It's not like they're going to send them home. So how about we have it that they're treating them as well as we're ramping up the treatment in the community for the people who inject drugs. And what we found is if we just added in for the first 5 years, treat the people that they're seeing without being ridiculous about it, not massively high numbers, that you could get this situation here where you've got no treatment. But most importantly, this is the slide here, is whereby basically adding in that we've got the prevalence, we've got the incidence right down, we've also had lower levels of cumulative deaths by doing that simple thing. So basically, treat all the people that are coming to see you in your tertiary hospitals, you'll stop your deaths, and treat all the people and set up programs to treat people who inject drugs, and you'll hit both of your WHO elimination targets without even being anywhere near as ambitious as our Georgian friends or the Egyptians. Natasha Martin and Peter Vickerman have essentially done some modelling which says pretty much the same thing. So it's basically, there's now, and again I'd like to acknowledge Natasha and Peter from this, but essentially saying the same thing. They're saying also it's that background prevalence does play a role here, but basically in terms of your benefit of who you treat, cost effectiveness and reducing disease, and these rankings held regardless of the cost of therapy. So what Natasha was saying is they're not recommending prioritisation or rationing. The modelling indicates that treating people who inject drugs early is cost effective, except when the chronic prevalence is very high. And settings with high hepatitis C may need scaled up harm reduction. And I think that's a really important thing for us all to remember and understand. And in low to medium prevalence settings, people who inject drugs should actually be prioritised. So that's what I'm saying, it depends on what we're wanting to prioritise. So access to care. I think this is perhaps more telling actually than prioritising, and I think Tracy really spoke to this well. So basically, it's possibly more telling issue is that many health services are not well structured to provide treatment to large numbers of people, even if treatment was affordable. Perhaps tertiary hospital clinicians should be prioritising their time, ensuring that treatment is moved to settings to ensure access to large numbers of people. What proportion of our time are we spending mentoring young primary care specialists who are not tertiary, they're not going to be gastroenterologists, they're not going to be hepatologists, they're not going to be ID physicians. What time are we spending doing that? What time are we actually spending setting up proper shared care facilities in our clinics back into the community and supporting clinics in the community where we may never ever end up seeing the patients? What proportion of our time are we spending putting political pressure on our governments to support these services? And what level of pressure are we putting on our governments as clinicians and providing advocacy to make sure that there is access to everybody? We need to stop stigma and discrimination against key populations. The fact that there are guidelines, the fact that in the United States, the fact that in many, many places in the world, people who inject drugs, or people who once upon a time injected drugs, or somebody because of some reason that is basically to do with them being vulnerable, cannot access health care. It's simply stigma and discrimination, and we should not be part of that conversation. We should be just saying it's simply an unacceptable thing. Also, the cost of testing is high, and it's often not easily acceptable. We need enormous work being put into this, and again, we need to be asking our colleagues when we go to conferences and all of those kind of things, what is going on to push along testing to make it accessible and affordable to all. And also the lack of approved point of care and rapid tests for hepatitis C. So, how to prioritise hepatitis C treatment from the perspective of the medical community? In my view, treat the patient in front of you, or in front of your nurse, or in front of the primary care practitioner you support, or via telehealth, or whatever it may be. And what are you doing to help that happen? And make sure you have a system of providing healthcare that means all patients can be in front of you, and it doesn't actually necessarily have to be in the chair, but that's what we need to be thinking about. I'd like to acknowledge a number of people who've been involved in the modelling in our group. Also Alex Thompson from St Vincent's, Peter and Natasha and the funders. Thank you.